West Africa has been affected by the worst Ebola epidemic in medical history in 2014, and it's ongoing. The remote Macenta district in Guinea is the country's worst affected region, with a cumulative incidence which was 10 times the national figure. And my group and I aimed at investigating the impact of this epidemic on general and HIV care in Macenta. The study was done in the only HIV care facility in the district, which is called Centre Médical de Macenta, and is a public-private partnership between the Guinea Ministry of Health and a Swiss NGO, and is in partnership with the ID West Africa Collaborative HIV Study. And we focused on the main epidemic period, which was August to December 2014 in Macenta, comparing it between 2013 and 14. Service offer was continuous and unaltered at the Centre Médical, which was not the case in every healthcare facility in the region throughout 2014. But we found a massive impact on general services. There was roughly 50% drop in attendance in primary care clinic attendance, primary care clinics, and consecutively a similarly sized drop in new HIV diagnosis, in new TB diagnosis, and in enrollment into HIV care. So basically, people didn't turn up at the hospital. When we looked at HIV care, so care for people who were enrolled previously to the epidemic, we found that there was less of an impact. There was about a 10% drop in HIV follow-up clinic attendance. And interestingly, we found no increase in short-term loss to follow-up among the patients enrolled in 2014 compared to those enrolled in 2013. We conclude from that the Ebola epidemic has a massive public health impact beyond the actual Ebola morbidity and mortality. We also conclude that HIV care in such a context is, of course, challenging but not impossible.
The JICI study is a drug trial that tests an antiviral called favipiravir. Favipiravir is one of the promising anti-Ebola agents identified by the WHO for fast-tracking testing. The trial takes place in 4 Ebola treatment centers in Guinea, mainly in the Southern Highlands, the region where the epidemic began more than 1 year ago. Since mid-December 2014, all patients with Ebola virus infection who present to these centers, in addition to standard supportive care, were offered inclusion in this trial that provides a 10-day treatment with favipiravir. The trial addresses 2 main questions. First, is mortality in patients who receive favipiravir is lower than mortality during the 3-month period immediately preceding the trial? And second question, does Ebola viral load decrease rapidly in patients who receive favipiravir? Among the 81st participants in the JICI trial, we clearly found 2 distinct groups of patients with very different initial characteristics, different outcomes, and different expectations as regards to the potential efficacy of the drug. One group, composed of 42% of all participants included in the trial, had a strongly positive PCR test, as indicated by a low cycle threshold value below 20, reflecting a very high viral load of approximately 8 log copies, which mainly accounts for 100 million viral copies per milliliter of blood. These patients had advanced disease complications, in particular acute renal insufficiency. During the trial, 93% of these patients died. And in the 3 months preceding the trial, mortality among individuals presenting with a similar level of Ebola viremia was 85%. Thus, it is highly unlikely that favipiravir monotherapy will ultimately be proven to reduce mortality in this population. The other group of the trial participants 58% of patients enrolled had a cycle-threshold value reflecting a high or moderate viral load. Among these patients, visual consequences of the disease were less frequent and mostly reversible. During the trial, 15 of patients in this group died. In the 3 months preceding the trial, mortality among individuals presenting with similar viremia was 30%. Comparison of the trial and pretrial data therefore suggests that favipiravir monotherapy may reduce mortality in this population. With this classification into 2 groups, we have a much better understanding of Ebola virus disease and can reassess the place of antiviral monotherapies in the therapeutic arsenal used against the disease. We know that monotherapy with favipiravir will not improve survival in the group with advanced disease, and we call for other interventions to be urgently tested in this group. We have the initial impression that monotherapy with favipiravir could improve survival in the group with less advanced disease. And the continuation of the JICI trial will try to reinforce evidence and confirm that it is firmly the case.
I'll be presenting the MSF response to the overall West Africa Ebola epidemic in the context of a description of the epidemic and in the context of the international response, which in summary is too little, too late. With more than 23,000 confirmed Ebola cases and more than 9,000 deaths, among which 500 healthcare workers today, a long-lasting disastrous effect on the health system and the economy, leading to the loss of many more vulnerable lives, the Ebola epidemic in West Africa will leave an ugly scar that will persist for decades. It will remind us of the negligence of the international community to act timely. This disaster could have been prevented. It was not overseen, it was ignored. Since March 2014, MSF sent to Guinea, Sierra Leone, Liberia, Mali, Nigeria, Senegal, DRC teams, more than 1,400 tons of supply. Over 8,000 patients were admitted in one of the 22 Ebola management centers that MSF built over the course of the epidemic, of which more than 5,000 were confirmed and 2,300 survived. The organization currently operates 8 Ebola management centers with 650 bed capacity, is active in all the 6 pillars that constitute a proper Ebola outbreak response, namely community sensitization, case investigation and contact tracing, safe referral, safe burial, isolation and care, infection and prevention control, and support to non-Ebola health facilities. We distributed several million anti-malarial treatments and more than 5,000 home and disinfection and protection kits. Since March 2014, MSF repeatedly called for help. In March, we alerted the world that this epidemic was different, reaching for the first time, different from previous outbreaks, which were mostly rural and confined to small villages. For the first time reaching a large city, Conakry, and needed urgent international support. In June, we highlighted that the epidemic was out of control with more than 60 concurrent outbreaks across Guinea, Sierra Leone and Liberia, including in all 3 capitals, and that the response capacity was completely inadequate, reaching far beyond the limits of MSF. In July, we called for state intervention as the outbreak clearly outstripped NGO capacity. In August, finally, WHO acknowledged that Ebola was a public health emergency, and we started having the first tiny steps of a response. In September, we called for civil and military biohazard capacity to be deployed. And from October onwards, after additional resources had started to flow in, we called for better coordination and flexibility of the response in order to adapt to permanently changing epidemic. The result is that we had an outbreak in 5 waves, peaking in April, May, and December in Guinea, in September, October in Liberia, and in December in Sierra Leone. Except for the first one, each of these peaks could have been prevented by implementing a full outbreak response in time and with sufficient resources. This outbreak is not over, and it remains unpredictable. This ongoing widespread transmission and geographical spread, both in Guinea and Sierra Leone, whilst in Liberia, the number of cases has gone down dramatically. Spread to bordering countries, especially Ivory Coast, is still a risk with new cases in prefecture from Guinea, Lola, adjacent to Ivory Coast. New cases increased again after a drop in January, 144 new cases in the week up to 8 February, 65 in Guinea, 76 in Sierra Leone, 3 in Liberia. Even with just one case, we can have a new outbreak. Any complacency would now jeopardize the progress made. So what still needs to happen? Actors need to focus efforts on addressing serious weaknesses that remain. First of all, contact tracing and surveillance. Last week, WHO reported that in Guinea, only 17% of new cases were on a contact list. In Liberia, that was 33%. In Sierra Leone, the data is not available. Without massively scaling up surveillance and contact tracing, we will not finish this epidemic. Regional coordination of this surveillance is of utmost importance, as these borders are porous and we need to prevent a reintroduction of Ebola in currently Ebola-free zones. Access to healthcare for non-Ebola patients is insufficient and unsafe. Already weak public health systems have been seriously damaged by the epidemic. In Liberia and in Sierra Leone, many hospitals shut their doors with very few places for non-Ebola sick people to turn for help. Some of these health services are reopening. Some actors are supporting infection prevention and control, but mostly in primary healthcare with very little support to secondary and tertiary hospitals. Stigma and hostility towards healthcare workers and survivors is still a big problem, as is general information of the population. In Guinea, attacks on healthcare workers are increasing, caused by stigma and fear, but are preventing teams to access suspect cases and to conduct proper community mobilization. As happened in Farana, last week, MSF teams were attacked, our car was burned, several staff were wounded because people thought we were going to spray Ebola in the schools. So community sensitization and health promotion need to be reinforced. MSF opposes forced quarantine, as is still happening in Sierra Leone and in parts of Guinea. And then lastly, we need decentralized full rapid response capacity. As new cases continue to appear in new places, the only way to stem the outbreak is to establish this full response on site as soon as possible. This epidemic has been extremely challenging for MSF. We reached the limits of our human resource and our supply capacity, heavily pressured by the need for experienced staff, by contamination of our own staff. We lost 14 staff of 28 MSF staff who was infected with Ebola, by the difficulty to solve medical evacuation capacity. The focus on isolation and care at the beginning didn't allow initially to fully cover the response everywhere, with gaps in health promotion, contact tracing, safe burials, and infection prevention and control. The constant need to adapt to ever-changing epidemic required a very high level of flexibility, further straining our human resource capacity. And then many challenges lie ahead in terms of reconstruction of the health system, economic impact of Ebola and emergency preparedness. This epidemic has taught us that there is no functioning global response mechanism to a potential pandemic in countries with fragile health systems. A clear gap still remains between the commitments made and the direct action that is desperately needed. Thousands have died because of international negligence, including many healthcare workers of West Africa desperately trying to contain the outbreak with the limited means they had. These are the real heroes of this epidemic.